Hello, welcome to ESGO 2024 Congress Interviews. My name is Seda Sahin Aker. I'm the ENIGO Turkish National Representative and the Old Editorial Fellow of International Journal of Gynecological Cancer. Today it's a pleasure and honor to be Professor Scambia, and we will talk about the ESGO and ESG guidelines about fertility-sparing treatment in ovarian and cervical cancer.
Hello, I am Beatriz Navarro. I am a gynecologist oncologist in Hospital Materno Infantil of Las Palmas, and I am one of the 2024 editorial fellows. So we are going to start with the question about fertility-sparing in ovarian cancer. So, Dr. Scambia, in your guidelines, you said that hem tumors of stage 3 and 4, we can do a preservation of fertility. So I would like to know how do we do that, because we start with 3 to 4 cycles of BEP chemotherapy, and then what do we do after that?
So the basis of this guideline is the fact that germ cell tumors are very chemosensitive. So you can perform in advanced cases chemotherapy, and then you can check by surgery if there is any residual tumor, and so you can remove the residual tumor, or if not, you just check, and then you can have a fertility-sparing treatment like this one.
Okay. And also I have another question, because you also said in our guideline that for a non-epithelial tumor, we have to wait 6 months after we can do a fertility treatment, and with epithelial tumor we have to wait 1 year after we do a fertility treatment. Why is that?
Okay, this is only an expert opinion, because unfortunately in this field we do not have any strong data supporting any kind of conclusion. So in many cases the guidelines are based on expert opinion, and discussing among ourselves, we decided that this could be a safe interval in order to have a pregnancy.
Okay, thank you.
Let's talk about fertility-sparing treatments in cervical cancer. I want to ask that after CONSERVE and SHAPE trials, how did the studies implement the fertility-sparing treatments?
Yes, both studies are very useful in order to draw conclusions on fertility sparing. This is because both trials supported the reduction of aggressiveness of surgery in patients with early cervical cancer. So this means that in the fertility-sparing treatment we can use conization in many situations, or simple trachelectomy, and we know that from an oncological point of view this is safe, but the obstetrical outcomes are much better. So I think that both trials are very supportive of our guidelines.
Thank you. The next question is, fertility sparing is a great necessity for patients. What's the criteria for the neoadjuvant chemotherapy following surgery, and in these patients, how do you implement the cervical lymph node concept?
Okay, so the use of neoadjuvant chemotherapy has been included into the guidelines because we know that in tumors bigger than 2 centimeters, between 2 and 4 centimeters, you can do radical trachelectomy, and we suggest to do this by an abdominal way, even minimal invasive, but by an abdominal way, or you can do neoadjuvant chemotherapy and then conization or simple trachelectomy if you get a good response. And probably from an oncological point of view, both situations are similar, but from an obstetrical point of view, neoadjuvant chemotherapy and less radical surgery gives better oncological obstetrical outcomes. As far as lymph node evaluation, we strongly suggest to perform sentinel node or lymphadenectomy before starting neoadjuvant chemotherapy.
Thank you.
Thank you.
Thank you. So thank you very much, Dr. Scambia, for this guideline who is going to help us to improve our clinical practice.